There we go. I think we're set.
Okay.
Good. So I'm going to be providing a quick overview of some sort of emerging and trial designs, and especially the pragmatic trials, and just thoughts on quasi-experimental as well. So if we start with, there we go. If we just go back to the basics of sort of randomized controlled trials 101, with our simple parallel arm RCT, in this case with a binary outcome, so a yes/no outcome with presence of transfusion or mortality or MI, yes or no. This has really been the mainstay of randomized trials for at least the last 50 years. And so many of the RCTs follow this format where you take a study population, you randomize the interventions, treatment or control, you follow those patients up, and then, as I say, you assess for their outcomes, and then you analyze the between group differences, what the total events in the treatment or the total rate in the treatment versus control. You may have an independent data safety and monitoring committee that oversees and provides independent looks at to oversee safety throughout the trial. And these simple RCTs, like I say, have been really the mainstay for the last 50 years. But the key elements here for these simple trials, randomized trials, is obviously the randomization. This is where you process assigning patients by chance to treatment and interventions, or that flipping of a coin, although it's done by ideally by centralized computers. You have allocation concealment, so everybody in the trial does not know what you are going to be randomized to ahead of time, because if they did that, they may make different decisions of whether they go into the trial or whether physicians place those patients into trial. Robust analysis is obviously a key element of RCTs. We try to stick to the intention to treat principle. So you analyze the patients as they were to the groups that they were randomized, regardless of what happens to them once they're randomized. They may cross over, they may drop out, etc. You want to adhere to the intention to treat principle. And then the fourth, if you can, is we want blinding. We want to keep at least the study participants, but also everyone else involved in the studies, blind to the treatment they received. So randomization is a central element here, and it minimizes biases of known and unknown confounders at baseline. That's one of the greatest advantages of randomization, because you have an equal chance of being in the treatment or control group. And all four of these elements, randomization, allocation concealment, blinding, and intention to treat analysis, they protect or minimize selection bias or information bias. And selection bias is getting in or out of the study, and information bias is the data collected when you're in the study. So despite 500 names for bias out there, there really are two categories of bias: selection bias and information bias. And as I say, these four maneuvers help minimize bias, which is absolutely key in protecting internal validity. These simple trials also have disadvantages. Sometimes it's the generalizability of results, or what we call external validity. So the trial participants, those who actually end up getting into the trial, don't necessarily represent the general study population that you're after. And we know, in certain populations, like you take cancer trials, that only 2 to 3%, I think at best 5% for some cancer types of patients are randomized into trials. So the flaw there is that those results in those trials may not be generalizable back to the target population. Recruitment is also hard. It takes a lot of time to screen and enroll patients. Some patients and providers don't accept randomization. A lot of participants do refuse based on that because they want to receive the best treatment. If at the time. They're administratively complex. There's a whole bunch of ethical and regulatory issues, not just with our federal regulator, but even local regulators, our ethics boards, and so forth. It's a lot of work, and in most of the cases, expectedly so. Contracts, coordination, etc. All this adds up to high costs. These simple parallel arm trials are incredibly expensive, and especially compared to observational research or big data research and so forth. So all those costs and the complexity has necessitated the need for innovative designs and analyses, and so I'll walk you through some of those now. The first one is factorial trials. Factorial trials are where we test more than one treatment. And that's where the name factorial comes in, is, the intervention is a factor. It tests more than one treatment or intervention simultaneously. And it does so by comparing each intervention alone and in combination with the other factor. And this is highly efficient because it allows multiple hypotheses in a single trial. Rather than a multi-arm study where you're randomized to multiple arms, here you're randomized to the combination of those interventions. And then the sample size is usually determined by the comparison that produces the highest sample size. So if you have two factors, treatment A and treatment B, the treatment A versus control, if that's the highest sample, if that determines the highest sample size, that determines the sample size of the factorial trial. You'll see more in a couple slides. And like I say, the factorial design, by simultaneously randomizing to more than one treatment, is actually much more efficient than multi-arm trials. And an early example of such trials was the Physicians' Health Study conducted in the late 70s and early 80s. I think it wrapped up in the mid 80s. And the Physician Health Studies was randomizing, the participants were physicians, and they were randomized to test whether aspirin versus placebo reduced myocardial infarction. And at the same time, they were testing whether beta carotene versus placebo reduced cancer. So an example from the transfusion field, I found this protocol that was recently published last year. And it's a study protocol for a multi-center 2x2 factorial, so two factors here, randomized controlled trial evaluating the interest of in this case, it was IV intravenous iron and intravenous and topical tranexamic acid to reduce blood transfusions in hip fractures. And so here you can see my arrow. Yeah.
Yes. Yeah.
Okay, great. So here they randomized into a 1:1:1:1 ratio. So there's 4 groups, and there are 2 comparisons. The first comparison was IV iron versus placebo. So here, this would represent the placebo arm when comparing to IV iron, which is this arm. And then the other one was looking at TXA, so a TXA arm versus placebo arm. And as you can see, they were randomized in that 1:1:1:1 ratio. So in your placebo arm compared to tranexamic acid, you have a total, a complete placebo arm, which is placebo TXA and placebo iron. But you also, in the placebo TXA arm, have an intravenous iron arm, okay? And so the setup here is that there should be no interaction between TXA and intravenous iron in this case. So here, you can answer 2 questions in one study. You can answer whether TXA is better than placebo, and you can answer whether IV iron is better than placebo. So the key assumption here is that these treatments don't interact, right? And that's the key. So if we go back here, if in the placebo arm that receiving intravenous iron arm can dilute out any, if there is an interaction, will dilute out any effect of TXA versus intravenous versus placebo. And so we need to be very, very careful that there's no interaction in these studies. So getting back to the Physicians' Health study, that the effect of aspirin on MI is the same with and without beta carotene, which is easier to sort of hypothesize for that study. It's actually less easier to digest or hypothesize for the previous study in hip fracture, that there wouldn't be an interaction. But so be it. And the sample size, again, is based on this key assumption that there's no interaction. If there is a little bit of interaction or moderate interaction, then you have to adjust the sample size. And then they become far less efficient because the sample size increases a fair amount. In some cases is up to four times. Yeah, so that's a factorial study. And although they're very seductive, they can be problematic. They're problematic in working through whether there's interactions or not, because all that has to be done prior to the study starting, because you have to know what the sample size is. And you can end up running these studies and having a presence of interaction, which dilutes out your effect essentially, unless it's a very high interaction. You will dilute out effects, and you'll find null findings for both of your comparators. In this case, it was IV iron versus placebo. You may not find an effect because there is interaction, and same with the tranexamic acid versus placebo. So they're best used for completely unrelated research questions. And so there's no interactions between treatments and outcomes. They've been growing, factorial trials have been growing steadily since the early 2000s, just because of the reasons that you can conduct two trials in one. If you have three factors, you can study three studies in one. And so you gain in their efficiency. But again, a caveat is you have to ensure that there's no interaction.
Dean, could I just interrupt for a second and ask a question? How well do you think the scientific community is doing in addressing that consideration about interaction between multiple treatment interventions? Particularly, I'm thinking just about what's been going on with COVID-related research, where there's been a huge emphasis on factorial design. Are we actually following best practices, you think?
I broadly speaking, I don't think we're doing a great job at it. I think we're not thinking through the potential interactions. And because again, if you have a lot of interaction, it helps you. They become actually more efficient. But when you have, a bit of interaction to sort of moderate interaction, they're game killers. And so what ends up happening is you have these null results, maybe somewhat promising, but not statistically significant or clinically significant results because of this interaction. And I don't think we've given enough thought to it. I know work a fair amount with critical care physicians, and there's a lot of factorial trials in critical care. And again, I don't think they've fully thought through the implications. Good, especially, and I'll also add, especially when there's a lot of these large trials end up having null findings as well. So it just plays into that I think we need to think through. There's so many different co-interventions in that mediate response. Okay, so factorial trials, I'll just, there's a couple resources here. I've got resources after each little section here that you can go back to, because we'll share the slides and you can go back to these. So quasi.
Sorry, Steve, can I just ask a question? It's funny, I just recently took a course in planned experimentation, but it was more about quality improvement, and it was very much about factorial designs. But I guess it's different because you are looking at like real life practice. You're looking at, you know, how you change things within a system, as opposed to showing that one is definitively better than the other, I guess. I don't know if you can comment a bit on that, because you know, obviously real life, you have multiple interventions that are happening at the same time.
Yeah, I still think you need to think it through. Again, if you're, you know, you're looking at two unrelated questions, or two or more unrelated questions, you're pretty safe. It's just when the questions, you know, if you're after the same outcome, or the treatments are fairly similar in terms of what their intended effect are, you know, so in the case, you know, reducing transfusion, you have to be very, very careful. So if you're, you know, looking at, I'm just thinking, you know, in this case, if you're looking at one that's reducing, you know, something reducing perioperative infection, and another looking at, you know, reducing perioperative transfusion, you know, there is some relatedness, but generally they're unrelated. So, and that would apply to sort of quality improvement exercises as well. Or you may be interested in the combination of those factors as well, right? So, so a bundle of care or management interventions, and then that's fair game.
Yeah, like I think the examples would be, you know, one ward gets this intervention, another ward gets, you know, this intervention, and you've got another ward that gets both, and you're looking at, you know, what those responses are to each of those. So I guess it's a little bit different in terms of the QI aspect. So
yeah, it can be. Yeah. I mean, generally, a general approach is to try to bring in the same rigor, but the reality is the real world doesn't, you know, it doesn't always conform to, or, you know, you can impose rigor in some areas that it's just too difficult. And it kind of actually lends into the quasi-experimental studies, right? Which can be incredibly powerful. And they don't get their just due, to be frank. I think, you know, again, because of the high cost of trials, and the innovations that we have in terms of big data and the quality of data that we have, we should be thinking more along the lines of conducting quasi-experimental, especially for quality improvement exercises and sort of the borderline quasi or QI and research blends. So quasi-experimental designs, they involve assignment to treatment, but it's not based on chance. So there's no randomization. The investigators still manipulate when the intervention is introduced, but it's not due to random chance. And so they're highly practical when we can't randomize. It's just infeasible to do. It could be sort of a hospital-wide evaluation, or a health system-wide evaluation, that it'd just be impractical to randomize whatever your unit, could be the patients or docs or nurses or whatever. It's just impractical to do. When it's unethical to do, so you know, to certain interventions, you couldn't randomize deleterious, you know, healthy behaviors like smoking or drinking. You couldn't randomize one to one of the groups, or to each of the groups. And they're also important when there's external validity concerns. So when we want to increase that generalizability, but we know if we introduce randomization, we're dealing with a very narrow slice of participants, then we want to turn to quasi-experimental because they can go much broader. Okay, so because you don't have that randomization, we need to be thinking of controlling internal validity to maximize internal validity. Yeah, we need to maximize internal validity because of the absence of random assignment. So again, what's important here is quasi-experimental designs are still experiments. The investigators are manipulating, and they can provide information about cause and effect. And here the independent variable, or your exposure, your intervention, is manipulated, but participants aren't randomly assigned. And as said, they must overcome threats to validity, especially internal validity. So, so a simple quasi-experimental design would be a single group experiment where you have observations done on a group. You introduce the intervention, and then you have post follow-up observations on that same group. So this is a typical sort of one group pre-test or one group before and after test. And then if you introduce, it's funny, it's not working there. And if you introduce a control arm, then it becomes a sort of a before and after study where you observe the same it's the same time points in the control group. They're not introduced to the intervention. And then in the follow-up period, you're taking observations in that group as well. So that comparison between your experiment, where you introduce the treatment compared to the control, will give you a much more robust answer response than it would if it was just a single arm experiment. And then you can play around here. You can have what we call an interrupted time series, is where you have more than one observation at baseline. You introduce the treatment, and then you have more observations post-treatment. And so the number of observations feed into how well you can characterize that group before the treatment was introduced and after. So you minimize the variability, or have a better appreciation of the variability before the introduction of the treatment and then after. And so it's much more powerful than just a single measurement before and after the treatment is introduced. And even more powerful is when you have introduced the control group, where you have the same amount of baseline observations. Obviously in the control group, the treatment isn't introduced, but you have their follow-up observations as well at specified time points. So this design here, which we call an interrupted time series, is incredibly powerful. But it's incredibly powerful if you take care of all the concerns that you have, because there's no randomization. So a classic textbook by Shadish, Campbell, and Cook, they suggest 3 considerations to maximize quasi-experimental designs. They're especially interested in that interrupted time series as being very powerful. And what you have to do here is you have to identify and evaluate all plausible threats to internal validity. Again, you don't have randomization to have, balanced known confounders and unknown confounders. There's no blinding, and obviously there's no allocation concealment as well. But you can control within these quasi-experimental design. You can have multiple control groups, you can have multiple baseline observations, you can have multiple post-treatment observations, and all that will help reduce bias. And importantly, it's your choice of control groups. So you want to really think about what your control groups are. If you're introducing an intervention at one hospital and you need a comparator hospital, you need to ensure that comparator hospital is very, very similar to the hospital that you introduce the intervention to. And the third one is sort of what I was just talking about, actually, is the coherent pattern matching. So pattern matching was a big deal in the 60s and 70s and 80s. And it's essentially looking at how groups are behave and expected to behave. So groups could be hospital wards, it could be hospitals themselves, and looking at the patterns of observations. And it's analogous to choosing the right control group. You want to choose a control group that's very, very similar to your intervention group or your experiment group. And when you do that, then the patterns seen after the introduction of the intervention should be due to that intervention, not just the groups you've chosen. So Shadish, Campbell, and Cook identify 9 threats to internal validity. And internal validity is everything, right? You need internal validity before you can even consider generalizing your results or external validity. If you don't have an internally valid result or a biased result, if you do have a biased result, then generalizability is moot. So they identified 9 different threats to internal validity, and they're presented here. What's really important is actually threats 2 through 8. 1 is obvious. 1 just is that sort of temporal precedence. You want to ensure that your exposure became before your outcome, not the other way around. And number 9 is the additive and interactive effects of threats. So it's just more than one of 1 through 8 that they can be additive and obviously more problematic. But if we focus on 2 through 8, the first is the first is selection, and that's systematic differences in who's in each of the groups. And because if you have differences in your groups, then you will have likely that could account for the outcome difference. History, it means the events occurring concurrently with exposure could cause the observed outcomes. So if you intervene with a new policy and you didn't realize that there was either other policies were introduced at the same time or at about the same time, or other interventions at the same time, you can't disentangle what intervention actually led to the effect. There's also maturation, which is the natural occurring changes over time. Could be confused with an effective exposure. I've got a potential example of that coming up. This is that change and this is key for clinical practice. It does change over time, and if you're just catching that trajectory of going down or up, that may be accounting for your effect, not your intervention. There's regression to the mean. So is when you go in and you tap the observations in each of these groups, you could be catching them at a time where they have high values, and naturally over time they would lower, or they could catch them at a time they have low values and naturally would regress back to the mean. And that's a big deal if you don't have multiple observations. If you have multiple observations, that's less of a concern. Testing, so number 6 is testing, and that's where, having been tested and patients or participants knowing what that test is and becoming sort of numb to it or knowing how to respond can also affect. So if they know, they filled out 3 pain questionnaires before the intervention came in, the intervention comes in, they're given the same pain questionnaire, they may know how to respond or respond differently because they know they've had the intervention or treatment. Instrumentation is just how we measure things over time may change. So different instruments, different pain scales, different ways of diagnosing or categorizing disease may change over time. So those with the long time horizon may be susceptible to instrumentation threat to validity. And finally, attrition, number 8, is patients loss to the loss of respondents or participants may produce artifactual effects. So they may be related to treatment and you can't measure them, which is problematic as well. So understanding these 9 threats, and I've had the Shatters, Cook, and Campbell text. It's summarized in a couple papers as well. Is really key to doing any type of research, but particularly quasi-experimental and even observational research. If you're thinking about these 9 threats, or in particular 7 threats all the time, you'll have more rigorous studies. So, and this is what I did with the universal leukoreduction evaluations. We looked at, we evaluated in both neonates and adult intensive care patients. And so universal leukoreduction was introduced in Canada in the late 90s, 1999, I think over the summer. And so it would have been impractical or infeasible to actually randomize patients. We were thinking about a randomized trial at the time, and it was just impractical. So we turned to sort of a quasi-experimental before and after design. And I took the 7 threats produced by Shatters, Campbell, and Cook, as well as Campbell and Stanley in a separate textbook, and I applied those to our studies in the design of our studies to ensure that we dealt with each of these threats. And so in the paper, I lay out, how what each of the threats are and how we took care of them. So here's an example of an interrupted time series looking at clinical decision supports for reducing overuse of red cell transfusion. So bringing in, sort of audit and feedback, or in this case, a reminder or a flag, I should say, to those ordering transfusions. And in this case, if your hematocrit was greater than 21%, which is, I think, the hemoglobin of 70 or so, you were flagged and asked whether the transfusion was absolutely necessary or not. So what they did is a pre-post design. It was an interrupted time series. They didn't present the data by observations in this analysis. They just simply took pre and post. So pre-period, they brought in the decision support and then measured it after. And what we see is, fairly large differences in either receiving a transfusion or their marker was red cell, primary outcome was red cell transfusions per 100 patient days. And that went down from 9.4 to 7.8. And yeah, again, those needing any transfusion went down 1.4%. So across the hospital, you could argue this was clinically significant. And then it was backed up with statistical significance, so highly statistically significant results. But if you look a little closer, well, yeah, you see here when you break down the data. So in this period was the pre-period and the observations. And here in the post period was the observations. And what we have to be careful with is getting back to one of the internal threats was just maturity in historic, could be historical reasons, but just maturity is, it seemed like there was a decline anyway happening, in the pre-period, and that just continued in the post period. So we need to be careful that all threats to validity are considered. And in this particular paper, I quickly looked at the discussion, and they weren't referring to those potential threats that could help with interpretation. And so again, we just need to be careful that all threats are considered. So those are a couple of resources. Jacob, you got a question?
I do, and this is obviously a huge issue in any study where we're aiming to improve transfusion practice, because we know that transfusion practice is generally improving anyway over time, and so how to prove that your intervention was the reason, as opposed to just sort of the temporal effects that made it look like it was from you. The the tools that we are taught to use in quality improvement research to address that kind of consideration are things like run charts. And to be honest, I've taken some quality improvement courses, and I know what the rules of run charts are. That you have to sort of have a certain number above the the median, a certain number below after the intervention. But I've never really understood the statistical backing of that kind of rule of thumb. And I wonder, like, is that, these sort of feel like kind of two different worlds in some ways, these kind of research methodologies and these quality improvement methodologies, but in fact, we're asking the same question. So I'm wondering, like, so for this particular issue, when you're talking about, how you address biases from internal validity, are things like run charts useful in a study like this, or would that be like a completely different research design?
Yeah, no, I think they can be helpful. Here, I think it's how it's being analyzed, right? There are sort of more sophisticated ways to analyze to see whether the slope before and after are different, truly different. And here, I don't see, just eyeballing it, which is a key consideration. I don't see any difference, to be frank. But even with slight differences, again, they didn't factor for the slope that was occurring before. That's essentially it. But there are some more sophisticated ways of doing it. Or here you have to bring in a control group, right? So if you had, and they, in fairness to them, they were looking at another control group. It wasn't prominent in their analysis. But if you bring in a couple other hospitals that didn't bring in such a decision support, that would help. But I think the big picture is, aside from analysis and statistics, is just really thinking through what those potential biases are, right? What those threats are. And if one or two of them can't be overcome, then you need to move on to more elaborate study designs and or special considerations, again, adding more control groups or adding more time or whatever. But it is a big issue. There's no doubt about it.
Yes, I mean, I'd be curious to know what Yulia's take on this is as well, because she's also done similar training in quality improvement. But when you're designing a quality improvement intervention, it's just sort of assumed that there will be all sorts of threats, to internal validity. Rarely do we design our quality improvement projects in an attempt to neutralize all of those. And instead, again, this is what I took away from the training I got. There are these sort of rules of run chart. We just say, if you set a particular baseline and you show that after your intervention, you are consistently below that baseline, whereas before you were consistently above it, that is good enough. And I've always kind of wondered, is that really a statistically valid approach, just to sort of take that as a rule of thumb? Or is it just sort of a quick and dirty thing that we allow for QI research, and maybe for if it's maybe we're asking a slightly different question than proving the size of an effect, if you understand me.
Yeah, I mean, I think there are statistical process control charts, and there are sort of upper control and lower control limits that do represent 3 standard deviations away from the mean. So I actually think there's still the equivalent of a p-value that's associated with that, and I think the value is that you can see changes over time and specifically associate it with the intervention. For example, here you'd expect there should be like a step down or some change that kind of changes in this general process. So I do think there are statistical programs to help delineate that. I think it's the same. I do think the same principles are there. I think the samples sometimes are not necessarily as big as required for an RCT, but I think there's still some science behind the.
Oh no, there's definitely a science behind it. It's just, it seems to be a very different set of approaches, design wise than this study by comparison, which took a different approach. But in fact, if this had been designed, the study that we're looking at right here, as a quality improvement project, the data would have been represented in a very different way and would have been analyzed in a very different way. And I wonder, is that because we're asking a slightly different question if we're doing it as a QI project? Or is it because, we are expecting much larger differences and therefore require less robust statistical analysis to show it? Anyway, that's a much larger question, I guess, but this does come up a lot in our transfusion studies.
I do think that there's a difference between, I think also people have a harder time understanding, the QI process control charts as opposed to a pre and post and a p-value, like this table on table 2 is it's like obviously it worked, right? Whereas when you look at this figure, you sort of start to realize that that's not as clear. And I think that's what the run control charts, so the control charts will show. So anyway, sorry to interrupt.
Yeah,
that's good. Okay, so doing a whistle stop, I realize time here. I'll do a whistle stop tour of pragmatic trials. Pragmatic trials, the whole concept, more than 50 years ago, 55 years ago or so, in a paper by Schwartz and Lelouch, a wonderful paper that laid out the difference between explanatory and pragmatic attitudes in therapeutic trials. Essentially, explanatory trials were very lab-like to prove something, to prove a treatment actually has intended consequences, whereas pragmatic trials were on the opposite end of the spectrum. And a pragmatic trial is a design that mimics as closely as possible routine clinical practice, with the exception, and the sole exception, that patients are randomly allocated to treatment. So, ideally that, it's thought that pragmatic trials and results of pragmatic trials would be instantly relatable and implementable in clinical practice because they actually mimicked routine practice. So this was a very, very important paper and set out gradually, especially in the early 2000s and building in about 10, 12 years ago, pushing for pragmatic trials. And as I'll get to in a bit, that the pandemic has sent pragmatic trials in the stratosphere with different designs, and I'll get to that in a few slides. So key characteristics, because they need to mimic routine practice, is it's a very simple protocol, broad eligible criteria. Essentially, any patient that you would intend to treat with such an intervention should be enrolled in such a trial. So very, very, very broad eligibility criteria. Ideally, multiple settings, and again, no protocolized care except the intervention. It also, because it is routine practice, that any intervention should be effective, that are compared to each other. Efficient and simple data collection. So we don't have a 20-page case report form. It should be ideally even less than a page. That the important outcome, they're patient important outcomes or clinically important outcomes, and looking at global benefits and harms, and that they have adequate follow-up time. We're not talking days or weeks for most of these, that they're adequate follow-up time for those observations to occur. So Merrick Zworystein and Katie London from Western have a really neat paper that set out sort of how you would evaluate a trial on the explanatory and pragmatic continuum. They have these 9 domains that you would evaluate the trial, or when you're designing a trial or critically appraising a trial. And again, they touch upon a lot of the elements I just discussed. And so you can take those 9 domains and put them on sort of what they call the Prezi-2 wheel. So each of these 9 domains, and then you kind of rate each of these domains, your trial with each of these domains. And so as an example from vascular surgery, a trial that was designed to be fairly pragmatic, when you apply it to these criteria and rate, there are some elements that are not all that pragmatic. So in their design, they may have wanted to go back to make more pragmatic. So, you know, in the follow-up, how closely patients are followed up, the flexibility. So what measures are in place to make sure participants adhere to the intervention. They had very, very little flexibility. Whereas in a pragmatic trial, you've got to obviously have to give a lot more flexibility to how they adhere. So, you know, taking, you know, one of schedule 2 doses or 3 doses would be fair game in a pragmatic trial, not so in an explanatory trial. So the Prezi-2 and the Prezi-2 wheel are really helpful in helping design trials to ensure they're as pragmatic as possible. So again, that key ingredient in a pragmatic trial is that randomization. So you're mimicking clinical practice or routine practice, except you're randomizing. And so the cost of randomization is that some patients may receive a standard of care different from what they would have received outside the trial, because that's the whole idea of doing the trial. What's really important, though, is all patients do receive a standard of care or usual care, meaning they you know, again, they receive a standard of care, and the risks are no different inside or outside trial. But we have to be careful. We need to respect the patient autonomy to decide with their provider whether they go into a trial or not. But again, the only manipulation is randomization. So what ends up happening in traditional RCTs, like I said, all eligible people, once you go through the obstacle course of enrolling in a trial, you're left with very, very few people in the end that were originally eligible. Whereas in pragmatic trials, because you have looser or broader eligibility criteria and you know, lack of protocolization and so forth, that in the end you have a good representation of the original population, and we can then comment on effectiveness. Whereas traditional RCTs, it's a little bit more about efficacy. So some recent advances to facilitate pragmatic trials. So again, those key characteristics are the advances of you know, hospitalized systems of EMRs and EHRs, electronic health records, health admin data that we have provincially at ICES here, streamlined REB approval, so centralized REB in Ontario, and as well as a big game changer is alternative consent models. So we now have oral or verbal consent that's integrated into care, rather than a you know, 25-page consent form that nobody understands what they're signing on to. So those advances have brought pragmatic trials to the forefront. So, and a good example here is comparing our ABLE trial that we conducted versus the INFORM trial, looking at the trial age of stored blood. So these were both pragmatic trials, one more pragmatic than the other, taking advantages of those recent advances in data and consent. And so here we were looking at whether fresh RBCs were more beneficial compared to stored blood, with the thought that fresh was better. Both trials had null results, showing that fresh blood was no better than usual care. But here, the key difference is in the INFORM trial, they have waived consent. They looked at all hospitalized patients because they had the data infrastructure to do so. Whereas in the ABLE trial, it was sort of that sort of simple trial with case written paper-based, some paper-based. We converted to electronic case report forms. in 2,500 adult patients compared to 25,000. The ABLE trial took, I think it was 3-4 times longer than 3 times longer than the INFORM trial. And so the efficiency is in the INFORM trial, it came out to about $42 per patient versus over $2,000 per patient in the ABLE trial. So again, large pragmatic trials with broad criteria using data systems are incredibly, incredibly efficient. And so I'm going to race through here what the pandemic did to pragmatic trials. So what happened is the urgent nature to identify potential treatments for COVID-19 brought together a lot of the stakeholders, including governments and public health, recognizing that, geez, we really do need clinical trials and randomized evidence rather than an anecdote or presidential decrees. And they put up money available to start up such trials. And very, very quickly, and I was glad to be part of this right from the beginning, is that these innovative pragmatic trial designs came to the forefront. So making sense of all potential interventions that would be thrown around at the time, how in the heck do we study these? So pragmatic platform trials offered promise, and because we could look at multiple treatments, we could adapt to the pandemic waves by pivoting to hotspots. So these platform trials, which I'll describe in a bit, are multinational. And so if the hotspot was occurring in South America, we could pivot to the sites that were already enrolled in South America. And they were adaptive. They could adapt to new potential treatments by introducing new treatments and dropping old treatments. So the key elements, the 4 key elements are still there ideally. So randomization, allocation, concealment, blinding, and intention to treat. But now it's all under a single infrastructure, which we call a platform. We're looking at a single disease. So in this case, COVID-19. The multiple arms is important because they can look at multiple interventions, and multi-stage, meaning that they're done in stage, look at the data in stages and drop or add arms as needed. So back to our simple RCT, and then we put it on steroids, literally and figuratively for COVID. We get the platform trial, which is you take your study population, and now you're randomizing to multiple interventions, okay, and looking at data in multiple stages. So at the first interim analysis, you look at the outcomes, you compare them, and if things are going well, that treatment continues until you reach statistical significance, and that would be, in this case, stage 2. Treatment 2 was dropped because we found that dexamethasone was a favorable treatment. So that would be dropped. It would then become part of your control, your standard care in the subsequent stages. But here you can add treatments. So in this second stage, a new treatment was added, or you can drop a treatment because of futility. And so this became the mainstay within COVID-19 research in terms of ICU and ward trials. You can take it one step further and have pragmatic multi-platform trials. So platform trial A, platform trial B, and C, you can then bring their control and treatment groups together. Obviously, the same treatment would have to be in each of the platform trials, but it doesn't have to be at the same time, right? So this platform started when this one came on board, and then platform trial C, by any time from this point on, you could pool the results from all platform trials to get you even a more efficient and quick result. So there is a number. Recovery obviously was front and center. What we heard about, they were kind of first out of the gate, and the UK government stopped all other randomized trials, hospitals randomizing to other randomized trials to focus their efforts on the recovery trial. So thousands of patients were randomized very, very, very quickly. And so, in terms of the recovery trial, this date is slide is a bit dated now, but they very quickly evaluated 9 treatments. The ones in red were found to be effective and were brought into routine practice. So how much time? I'm right at time, Jacob?
I'm not going anywhere. I'd be quite happy for you to go a little over time, but I can't speak for everybody else. This was booked to end at 9, but if you're willing to go a little longer, I'm happy to continue.
Sure. I got a couple slides on superiority versus non-inferiority, because it actually is an important concept that has come in with pragmatic trials, where we're taking a new treatment and comparing it to a standard of care, or taking a couple different treatments, sort of standard treatments, and comparing them to each other. And it is an important concept that I'll just touch on, sort of briefly. So if we're looking at treatment A versus treatment B, there's 3 potential hypotheses. So as with any trial, we need to come in with a hypothesis. We just don't start studying treatment A versus treatment B. So the 3 potential hypotheses are that treatment A is better than treatment B. Treatment A is at least as good as treatment B. And then treatment A is equivalent to treatment B. So in the first case, treatment A is better than treatment B. We would call this a superiority trial, that we're after to prove that A is better than B. Whereas the second line, as least as good as, we consider as a non-inferiority trial. So, and I got the reasons on the next slide. And then the third one is when we want to show A and B are essentially equivalent or exactly the same, or within a very, very small margin, that's an equivalence trial. Equivalence trials are rarely conducted, because the sample size required to actually demonstrate such a narrow window, the sample size is through the roof, and usually tens or hundreds of thousands of patients needed. So they're not often done, but certainly superiority trials, which is kind of the norm, again, with more and more treatments and diagnostics and screening, screening interventions out in the field, so to speak, non-inferiority trials have become much more common. And what's important here is your sample size and analysis really depends on the chosen hypothesis. So if you choose a superiority trial, you need to calculate sample size and your trial analysis different than a non-inferiority trial. A bit more on that later. So when do you conduct non-inferiority trials? Obviously, it's to demonstrate that treatment is unacceptably worse than another treatment, so that non-inferiority hypothesis. They're generally used for comparative effectiveness trials, meaning active controls. It's certainly, you wouldn't do them with the placebo. There'd be no sense to comparing it to placebo. And when you hypothesize that non-inferiority or very little difference in effectiveness, but there are appreciable differences either in costs or safety or convenience or dose reduction or intensity, then non-inferiority trials become the approach that you want to take. But the key element here is defining that non-inferiority margin, because we're saying how, essentially trying to answer how unacceptably worse does it have to be to declare non-inferiority. So that's a really important concept, that you're sort of given that if you're trying to show treatment A is non-inferior to treatment B, it's because treatment B is a very effective intervention, but you're willing to accept a little difference because treatment A is less costly or much more safer. Okay. And so determining that non-inferiority margin, which we'll see on the next slide, it requires evidence. It requires stakeholder acceptance. So, your clinical colleagues need to buy in that such a margin is reasonable It's not too large because you don't want a huge margin, because then it becomes less clinically relevant. So putting these concepts together, one way of looking at it is so looking at the end game, what the possible conclusions from a non-inferiority trial are. So here, just to orientate you to the graph, that a difference between the two groups, a null difference, I should say, is represented by this red line. And then you have a difference, which becomes your non-inferiority margin. So here, this would be treatment B. It's the established therapy. This would be your established therapy. Here, standard therapy is better, and the new therapy is better on this side. And you set your non-inferiority margin to say, what is that acceptable difference? So it could be a change of 5% or an absolute difference of 5% or 1% or whatever it may be. And if your results fall within that margin, then you're fine. So with that margin in mind, say again, an absolute difference in transfusion or proportion transfused of let's say 2.5%. Okay, so null difference up to 2.5% difference in the non-inferiority margin. So what happens is you run the trial, you get a result that shows that new therapy is better. Well, then that's superiority. You're laughing, right? If you show a result where it's not statistically significant. So again, this is statistically significant. This isn't statistically significant, but it's certainly showing that the new therapy, trending towards new therapy, is better. That would be non-inferior. Similarly, if you're right on the null, because your confidence interval, your lower confidence interval doesn't cross that non-inferiority margin, again, it's non-inferior. Okay. Now, where you get into trouble is it's non-inferior in terms of the point estimate, but your lower confidence interval actually crosses that non-inferiority margin. So here it's like, say 2.6% or 2.8%. Then it's inconclusive. You need to go back and do another study. Okay. Whereas this one, it's because it crosses again on the non-inferiority margin, it too would be non-inferior and inferior, right? Where the treatment is the new treatment is not better than standard, but did fall within the non-inferiority margin. And then the final one where it's way outside the non-inferior margin, you would obviously conclude that standard therapy is better. So that's the philosophy behind it, is that what's really important is non-inferiority trials are for comparative effectiveness studies where you have standard treatments and you think one treatment is close to or as good as a current treatment, but brings costs or safety benefits. And when you want to do such trials, that specifying that non-inferiority margin is absolutely critical, and it has to be done again with evidence and stakeholder buy-in. So if you had your absolute difference in transfusion rates of say 15%, from say 30 down to 15% or 40 down to 25%, that wouldn't be a believable non-inferiority margin. That'd be just way too wide. So you can't just shift it, make it large because you want a smaller sample size. So I think I'll leave it there.
Yeah, that's fantastic. If I could just jump in with one very last question, and not to dominate here, but this is such an important topic for us. The TRICK trial, as you know, is designed as an equivalence study, and it didn't enroll enough patients to prove that. And so we kind of relied on secondary outcomes to make any kind of conclusions about the data. Would it have been acceptable to go back and say, okay, we designed this as an equivalent study, but we're actually going to analyze it as a non-inferiority study? Or is that not kosher? Once you've committed, you have to stick with your statistical plan?
Yeah, yeah. So no, you can go back and forth between non-inferiority and superiority, right? That's a common in the setup. So what it comes down to is in non-inferiority, you're dealing with a one-sided hypothesis, right? Because you don't care about whether well, you should care, but at the time you don't care. You just want to show it's no worse or as effective as your standard therapy. But you could very well leave it open that if it is better, you'll test for superiority, right? And that's happened a few times. So switching between non-inferiority and superiority is not an issue. When it comes, yeah.
What about between equivalence and non-inferiority? Because if with an equivalence study, you will not have defined a non-inferiority margin in advance, right? So you'd have to go back and create one. Would that sort of look like you were fishing for an outcome, though, if you did that?
Yeah. So for equivalence, you have to state what that you actually state what the difference, the equivalence margin is, but you can imagine it's very, very thin, right? And so then to revert to a non-inferiority, I guess technically, well, you can do what you want, but that is less rigorous than switching between non-inferiority and superiority, because of the philosophy behind your hypothesis. You definitely want to show two things are equivalent. They're not often done. That's the thing for those reasons. So that's why in superiority trials, although you think treatment A is going to be superior, you still leave it open that treatment B could be superior, right? So that's the two-sided hypothesis. Whereas in non-inferiority, you don't care about your new treatment beating the comparator.
Mm-hmm.
Yeah.
Any other questions from the other people who are online? Well, if not, I know we've gone over a little bit, but Dean, I think going over, because we've been peppering you with so many questions, I think just shows the value of the topic and how you presented it. It's so useful to us, and I'm glad we recorded it because I think everybody else in the group who wasn't able to make it this morning because of CSTM is going to really value going over your presentation again. So with that, I guess we will sign off, and Dean, again, thank you so much for taking the time to meet with us this morning.
Oh, no problem. My pleasure, and thanks for the invite.
Okay. All right. Good night. Or goodbye.